we're often concerned that our interventions are going to be different in different environments, and to have such robust observational data, I think, is an excellent prelude to a potential trial that we might all do together. And along those lines, it's my pleasure to next introduce Lin Wong from Singapore, from, I understand, Tan Tock Seng Hospital in Singapore, where she's a consultant in anaesthesia and intensive care, and is going to tell us about Singapore SPICE.
Good afternoon, everyone. Thank you for the kind invite to come here today to give a brief update on the Singapore SPICE. And I'm just going to also give you a brief geographical outline. So we are a tiny island, a red dot on the map. We're along the equator, so it's 365 days of summer, no winter, definitely no snow. We only have a landmass about 30 kilometers wide and 27 kilometers in length, and therefore you can transverse from one part of the country to the next, or the island, in a day, really. And with that, we've got really 4 major public hospitals with us. A, if you can see there, is Singapore General Hospital. G is National University Hospital. The complex of J, with its rehab hospital, is Tan Tock Seng Hospital, where I work. And K is one of our newer hospitals that was established and is working now, K. And these are 4 major centers where we are recruiting our patients for Singapore SPICE. And this is just a background. I think Yaya has gone through quite a lot of it. And in terms of, we know delirium is common and important because it affects our patients in terms of mortality, in terms of greater costs, as well as resource utilization. And really pre-SPICE in Singapore, we really had very little data on the incidence of delirium. We also had very little data on our local sedation practices. And we were actually still using Ramsay in the ICU for sedation scoring. And we never set sedation goals as part of routine management for our ICU patients. And I think that is slowly changing very excitingly for us. And therefore, Singapore SPICE, not unlike the ones that are done here, and this is done in collaboration with Australia, New Zealand Clinical Trials Group, was to define the sedation practices that were adopted locally in Singapore and to identify patients, site and treatment-related factors that were associated with the risk of over-sedation, especially, I think, in the first 72 hours. We also wanted to investigate the incidence of delirium in intubated and sedated ICU patients, and to assess the impact of delirium on patient outcome and resource utilization, and to study the influence of local sedation practices, and hopefully to be able to generate a guideline or a bundle of care that would suit our local practices. And therefore, it is a prospective observational longitudinal cohort study. And we practice a little bit differently in Singapore. So I know you have a closed ICU where everybody works in the same team. In Singapore, the surgical ICUs are run by the intensivists, stroke anesthetists. The medical ICUs are run by the respiratory physicians. So they're actually very separate ICUs. And that is probably one of the challenges which I'll come to a head for us as well. So in Singapore General Hospital, the participating ICUs are the surgical and the medical ICUs. In Tan Tock Seng, it is the same. It is the surgical and medical ICU. NUH, it is the surgical and medical ICU. And in KTPHD, surgical ICU. Our research board has also approved a waiver of consent in terms of ethics approval, and the plan is to recruit 25 consecutive patients from each ICU. And this is like Yaya's slide. It is patients eligible for the studies, not unlike the ones that are done here or in Malaysia as well, and the exclusion criteria are the same as well. So currently, I think very kindly, Yaya has actually come to Singapore to train our nurses. I don't have a picture-perfect shot of him with all our nurses, but he was here definitely all 3 days of it to train our different nurses in the ICU as well as the physicians. We have our system, we chart electronically, so not on paper, and I'll show you in the next few slides. So we call it the ICIP system, or the IntelliView Clinical Information Portfolio. And we've actually recruited our patients. Some of us have completed our recruitment as well, and data collection is still ongoing. Okay, so this is part of our electronic charting for all our patients in the ICU. And if you can see that, it says vital signs and then pain and sedation goals. So every day now, we've put it as part of our plan for each patient that you need to have a goal set for a patient, whether it be vital signs and pain and sedation is now part of it as well. And we do that in the morning, during our morning round. We have tried to put that as a default, but we use our RASS as 0 to -2 as our default, and anything else you can also then titrate according to clinical practice or clinician preference. Unfortunately, not all our ICUs are trained to use RASS and Chemice at the moment, and therefore you see right at the end we still need to have the Ramsey scores for some of the nurses trained in the different ICUs. And I think that's going to be a challenge for us in time to come as well. But that's got onto our daily goals, and so I think sedation is part of daily goals now, and that I think is a very good step progress for us from 6 months ago. The next slide I wanted to show you as well was we do our RASS scores hourly in the day. So from 8 a.m. to 8 p.m. it is an hourly RASS score that is done by the nurses looking after the patients. And then we want patients to sleep and rest as well. So from 8 p.m. we do a 4-hourly RASS unless indicated by the clinician. So then 8 p.m., 12 midnight, 4 a.m. and then 8 a.m. would be the next RASS score. And then we do our Chemice based on on your RASS scores for the last 24 hours at about 9 a.m. And so it is, if I can't use it here, but on this system it is pretty intelligent. So if you have a patient that is alert and calm, you just go down the screen and you put 0, so you don't actually have to remember it in terms of what the RASS is in terms of the number to that. And if the patient is anxious, then it's a +1. On each admission cubicle of our ICU, we have one of the RASS, and on the other side, the Chemice flow sheet as well, if nurses or physicians forget how the workflow actually progresses. And then in terms of the Chemice, that's also quite easy to use. So if you have a fluctuating RASS, and then you have a mental status that's different, and you have inattention, and if you do save a heart and you only get 4 out of 10, it immediately makes you Chem positive. So you don't have to go through it. And the computer would not let you do anything else besides that. And so the computer system would prompt you in terms of what your workflow sheet would do as well on paper. And I think that's helpful for the nurses as well and decreases their workload. Okay, so currently, Singapore General Hospital SICU hasn't actually recruited anyone. Unfortunately, the principal investigator there has resigned, so we're just trying to get started on that. But everybody else has really been on par. SGH has got 15. We have completed 25 and 25, both in surgical and medical ICUs. And NUH has got 30 and 30. And Khoo Teck What has got 13. So we're almost reaching our numbers that we want of 200 patients at the end. And it would be exciting to see what our results would be as well, actually. And so the problems we initially faced was really from nursing as well. It's a new workflow for them. There was a lot of resistance in terms of increased workload for them, new things to be learned from their point of view, and whether it really, they don't actually see the absolute better outcomes for patients. So we keep saying, you get shorter ventilation times, you get better outcome, but they say we don't actually see it in front of us. And how do you make us, how do you convince us that that's going to happen? And I think we've gotten over that as they see some of our patients get better with time, with less delirium, able to mobilize. And now we have a weekly rehab round as well in the ICU. And so we see patients actually getting more mobilization, less delirium in our ICU, really. I think the other thing to say is a language issue, which maybe we take for granted. But in Singapore, we are very multi-cultural. We have 76% of our population being Chinese, but we have Malay, Indians, and Caucasians as well. And a lot of the older generation don't actually speak English. We also have, and they speak Mandarin or Chinese dialect or Malay as their primary language. And we have nurses, and we have quite a big population of nurses who are not Singaporean, who don't speak these languages, and therefore they find it very difficult to communicate with the patients. We don't have one-to-one nursing, we have 1.5 to 2 nursing, and therefore the nurses find it difficult to do this on the morning when it's busy as well. And so we've gone through quite a lot of this. So we have managed to persuade them, and we've said, you know, you really only need to know 5 sentences when you do the Chemice. And you only, if you don't know numbers, if you don't know alphabets, we do numbers. So you only need to learn 4 numbers in a different language, and it's not that difficult. And I think they've come on board with that as well. We've had a laugh or 2, we've had a cry or 2, but I think it's gotten there. I think everybody's quite happy. So sometimes even I can't speak very good. My Malay is not very good, and I can't remember what a hammer or a sled is, and somebody will say, yeah, that's it, that's it. And so everybody's helping each other, and I think we are seeing the results, and I think that's nice. And like I mentioned earlier, we do have separate ICUs, and I think that's still going to be a big probably challenge for us. Our ICUs are not in the same unit, and therefore even if we convince our surgical colleagues or our medical colleagues, CCU is run by the cardiologists, cardiothoracic ICUs are run sometimes by the surgeons, and those are the ones that we find difficult to reach out to and say, come join us, this is what it is. And so our nurses are trained, but not all the nurses are trained to do the RAS and the Chem ICU from our point of view. And therefore it is the buy-in and training of all the healthcare workers in Singapore that I think would be the challenge going ahead. I put this up as the last slide. Singapore is a tiny but I think very vibrant and very fast-paced society. When I was in Melbourne, probably in 2010 for a year, this wasn't up yet. And when I came back, this was completely up. This is Marina Bay Sands, that's the Helical Bridge. Now Art Science Museum is out, and you can see Andy Warhol's works there. Gardens on the Bay will be up by September, and Poland, the restaurant, would have a branch there. And I really hope that our ICUs in Singapore would be the same, that all patients who go to a Singapore ICU soon would definitely have a daily sedation goal and would definitely be able to have a daily Chem ICU in terms of detecting delirium in those who are eligible for it. So yes, thank you.